Okay, hi everyone. Thank you for joining us for our elective student webinar for 2025. So we're going to be going through some student stories and student presentations from our electives. But just before we start, there's just a few housekeeping things as we go. So we are recording the session and we're going to upload it to YouTube afterwards so that anyone who's not able to watch live can join us after the event. We just ask for anyone who joins us that you keep yourself on mute and turn your camera off. That's just to help with any network issues that we might be having out in Malawi, just to make sure that things go smoothly. We're expecting to have a mix of people, so some of our hospitals will be joining us, hopefully. We've got a few other stakeholders in Malawi, including our students and colleges and our alumni that will hopefully be checking in. And we'll probably send it to potential or interested elective students for 2026 as well, just so that they get a bit of a flavour of what's involved. There's definitely the opportunities to ask questions after each presentation. Or you're very welcome, if you're not watching it live, just to drop us an email if you've got any specific questions, or if you are and you'd find it more convenient to put them in the chat box, then that's absolutely fine as well. So I'm coming from Malawi at the moment, so if the network drops or the Wi-Fi cuts out, I will pop back up. So for those of you that are watching live, just bear in mind there might be a few technological bumps along the way, but we'll hopefully do our best to keep things nice and smooth running. So our schedule for today, so the time shown are Malawi time. So you've got a few minutes with me telling you a little bit about our elective programme here in Malawi. Then we've got Tamara, who's based in New Zealand. Then we've got Sean and Isaac, James, and then Scott, who's done a poster for us. And then it's back to me at the end and just going through a few financials and impact and close. But as I mentioned before, if we've got any technical issues and with a few different presenters joining from a few different places, that schedule might change. So we'll just sort of go with it and hope for the best. So for those of you that don't know Medic to Medic, this is just kind of a little bit of an introduction, I guess. So Medic to Medic, we're a UK, New Zealand and Malawi registered charity, and we provide scholarships to disadvantaged students training as health workers in low resource settings, with our main projects being in Malawi. And our aim is to increase the number of health workers in countries where there are critical shortages and try and increase this vital component of health systems by having more human resources in healthcare. So at the moment with the elective programme this year, it's been really, really amazing. We've been able to push from sort of 80 to 100 students at any one time. I think we've now got 110 students in Malawi, and that's kind of down to us being able to increase our student scholarships from the fundraising that we've managed to get from the elective programme. So in terms of scholarships, what that looks like is it's a tuition fee payment for all the students until they graduate. We give a once a semester allowance, and then we also provide medical equipment, medical books, and a laptop as well. And we've got a whole range of health workers. So we've got medical students, dental students, pharmacists, physios, nurse midwives, clinical officers, psychotherapy students, like a whole range, which is really, really cool. So in terms of our elective programme, we started it at the end of 2023. Oh, I can see a typo already. So we're now 2 years into our operation of the elective programme, and it's grown nice and sort of sustainably over that time. We were initially just had a few students, but over this year we've increased the number of students that have come out with us, and we're looking forward to continuing to expand that as well. So we've currently got partnerships with 8 hospitals in Malawi, and we're in talks with one other hospital as well. So we can offer hopefully a range of experiences. We've got a partnership with a private hospital. We've got 2 central hospitals, a government district hospital, and then CHAM hospitals as well. We've also just managed to get a partnership with Zomba mental hospital. So there's definitely a few kind of different specialities and nuances between the different locations. And part of kind of the package that we offer is just that pre-departure support as well. So we can provide Chichewa language lessons and tropical medicine tutorials. They're given by our students. So our students do the Chichewa lessons, and then our graduates do the tropical medicine tutorials. And that's really great because at least, yeah, gives us a chance for our community to get involved in the elective program as well, and definitely sort of helps with a bit of cultural preparation before you arrive as well. And then when you're out here, we've got some on-the-ground support with our alumni, and we're trying to kind of develop that as we go at the different locations, and we give you advice sort of the useful items that you can bring out to Malawi if you've got space in your luggage as well. We do really strongly recommend undertaking an elective project, but that looks a bit different at each of the different locations, and can sort of vary from student to student as to what your interests are. And it's definitely not compulsory, but it's just something that we recommend for some quiet time or downtime that you may have whilst you're at your hospital location. So we've always got projects and audits that need going at Medic to Medic as well. So if it's not something that we're able to get permission for at the hospital site, sometimes those processes do take a bit of time, then we'll try and involve you in some sort of medic to medic audits that we've got going as well. So essentially the aim of our elective programme is that we're able to provide one Malawian student with a scholarship for 1 year for every elective student that comes. So that's why we're really trying to increase and strengthen our elective programme, because it has a huge impact on the number of students that we can sponsor out here. So just kind of giving a geographical overview of where our locations are. So Lilongwe is the capital of Malawi, so that's right in the central region. We've got partnership with St. Peter's on Likoma Island, which is a pretty unique place. It's an island which is closest to Mozambique on Lake Malawi, but is Malawian owned. And then we've got a CHAM hospital in Mzuzu, St. John's Hospital, our new partnership with Mzuzu Central Hospital, also in Mzuzu, as the name would suggest. And then we've got our other locations all in the southern region. So we've got Zomba Central Hospital, Zomba Mental Hospital, Maiwatu Private Hospital in Blantyre, Mwanza District Hospital right on the border of Mozambique, and then down south, Trinity Hospital in Nisanje. So one of the activities that we try and get elective students involved in, if the kind of academic schedules with the schools sort of allow, and if we've got the opportunity to go in and do that, is to do some school talks. So essentially that's a collaboration with our elective students, but also our Malawian students. And the aim is that our Malawian students would give some motivational talks on their study journey, what challenges they had, how they overcame them, encourage them to continue with school, but also try and help improve the health literacy and give a little bit of career guidance for students at school. So most students have heard of doctor and nurse, but not many people have heard of optometry, audiologists, radiographers. So it's partly to try and educate what other careers in health look like. It doesn't just have to be doctor or nurse, and then hopefully students can make informed decisions about maybe what they want to do at university. So as part of that, if we've got elective students in country at the time, then we do some CPR training and demonstrations just to get some students involved and learn a bit of pre-hospital care. So we do CPR, recovery position, and how to manage choking. And hopefully you can see a few of those pictures there. The other thing that we do for students in the southern region is we do a village visit. So this is at Nandala village, which is on a village in Malanji, which is again on the border of Mozambique. And this village was really badly affected during 2023 with Cyclone Freddy. And we set up a host scheme where students will go to the village for a night. They'll stay with a host family. We give them a fee for hosting the students. Expenses are taken off, which are essentially kind of food while you're there. And then after that, all the money that remains goes to a community fund, and there's a committee that decides how to spend it for the village. So far, it's been school uniforms for children in the village. And some school fees as well, and we're hoping to continue that. It's always quite a hopefully enjoyable activity. You haven't had any sort of negative feedback from it yet. And the main kind of village activities are learning how to play bow, which is one of the local games, practicing your chichiwa, experiencing village life, collecting water, going to the maize mill, going to the village clinic, and learning just how to cook some local meals. The other part of our elective program that we try and do well, I guess, is the carbon offsetting component. So we know that we're encouraging elective students to come to Malawi, which obviously does involve quite a significant international flight. Climate change is happening and is still going to be an issue for the years to come. So we wanted to have some kind of carbon offset component associated with that. So for every elective student that comes, we donate 200,000 kwacha, which is enough to plant 200 trees. And we support a northern group and then a southern group. So for students going to the southern region, we support Mount Sochi Conservation Trust. And in the northern region, it's Puwi Women and Youth Reforestation Collective. So we've just made the donations for the 2026 planting season, and we're hoping that between those two groups, it's going to be possible to plant 1,400 trees, and the survival rate from our contributions from last year is about 76%. So we've also got that kind of monitoring and follow-up. And this is just a short summary of how many students we've had during 2025. So we had 13 elective students. We had our first UK students this year, which is really great. And they were all kind of spread out from a range of different universities. And then from our New Zealand component, we've had 5 students from Auckland University. And the duration of the elective has ranged from sort of 4 weeks to 8 weeks, with an average of 5 weeks per student. And we had 4 students split their electives into 2 or more locations. So that's why our total for the number of students at each hospital is slightly more than 13. Most popular place was Zomba Central, and that was followed by Likoma Island at St. Peter's, and then Waiwatu Hospital. And we had our first students at Mwanza District, which was really cool, and then followed by the Cham hospitals as well. Okay, so now that's probably enough of me talking and with introductions. I'm hoping that Tamara has arrived, and I think she has, which is great. So, Tamara, when you're ready, thank you so much for joining us. I know that you are.
Okay.
It's very early, so we very much appreciate you joining us. So over to you when you're ready.
Yeah, I'll just share my screen. There
Awesome, we
we
can
go.
see that, so that's great.
Cool. Mm. Cool. So yeah, I was one of the elective students who did my elective at Zomba Central Hospital earlier this year, in I think it was April and May. So I'll just share a kind of a short PowerPoint about my experience there. So in terms of the hospital there more generally, it was a much larger tertiary hospital than I think me or James, who went there together, kind of realised. It has around 680 beds and serves a really large kind of catchment size of about 4 million people, and then included patients from neighbouring countries like Mozambique and Tanzania as well. So they have a very high patient load, probably like many of the big tertiary hospitals in Malawi. Often, I think they're over capacity or very much at capacity, and there were kind of patients always like lining the hallways and things as well. But despite that, we found it to be really supportive and safe. Uh, like it wasn't so big that you would get lost in the chaos. Everyone there was very, very supportive. And I kind of heard stories about students being pushed to do things that they maybe weren't so comfortable to do in other countries, like developing countries like Malawi. But Zomba wasn't like that at all. I was on Obs and Gynae for the majority of the time, and people would ask me if I'd done things before, and usually I hadn't, and then they would be very supportive and help me to then learn those skills. Like for example, for C-sections, a lot of the interns there who are first year doctors would be performing them by themselves or just assisted with other kind of junior doctors as well. And they would get me involved and let me be first assist with them Or the consultant there would kind of work with me to help me improve my suturing skills. I got to deliver some babies there, but that was only after working for like several weeks on one of the labour wards with senior midwife staff there until they were comfortable that I could kind of assess the stages and progression of labour by myself, and it was under senior supervision. So I felt really well supported, which was really, really nice. Yeah, and you see lots of presentations that you obviously never see in developing countries like New Zealand, particularly kind of infectious disease type cases. Yeah, like I did a week and a half, 2 weeks on general medicine as well, and I got to see late stage HIV where people's CD4 counts were less than 200, and so the patients had lots of the weird and wonderful infections you only really like read about in medical school, like cryptococcus. And I saw tetany sieges and late stage preeclampsia and like huge fungating cervical cancers. There was lots of tuberculosis. But yeah, it was really, really fascinating. So just run through kind of a day in the typical life there that we were living. We wake up pretty early around 5:30, which is kind of the time everyone else seemed to wake up around, and that's where the sun was coming up. Have a little workout where we were staying, which was nice. And then we'd have breakfast for the morning with our very expensive instant coffee because all of the imported goods there are very, very expensive. So I think we got a tiny thing of instant coffee for like 20 New Zealand dollars. And sometimes the power would be out, so they would cook that over our gas cooker. But it was always lovely. The sun was always coming up, and it was a beautiful morning, always in Zomba, looking out over the plateau. And then we would go to ONG handover, which started at around 7:15 a.m. and went for a really, really long time. It went for about 2 hours, which is also very different from back home in New Zealand and the handovers and how long they ran here. But I found the handovers probably some of the best learning experiences that I got to do, just because the head of the department, Dr. Gabaya, who was my supervisor, would kind of run them and would essentially use it as a teaching opportunity. And so they would kind of run through all the patients on the wards and go through almost every detail, but he would frequently stop this and like ask questions and then use it as a teaching opportunity and kind of go around the room and ask either the interns or some of the students if they knew what was going on and for definitions and things like that. And then by the end, he was involving me in that as well, which was good for my learning too. So I feel like I really learned a lot in those handovers, and they were all conducted in English as well. So they made it very easy to understand what was happening and to join into. And then basically it was very self-directed, as in Elective probably is most places. And so I could basically choose where I wanted to be for the day. It was split into, the labour ward, the maternity ward, the gynae ward, gynae clinics, operating theatre, and the postnatal ward. And you can kind of get as involved as you want. It's really about kind of speaking up and saying what you're interested in and getting out there and figuring out what it is that you want to do. I ended up spending I think splitting it into like 2 weeks on the maternity ward, 2 weeks labour, 2 weeks gynae, and 2 weeks postnatal because I was there for 8 weeks in total, with time going to gynae clinics with Dr. Kabaya and some of the other seniors, and also I'd spend at least a day or two a week in the operating theatres as well. Um, and the point of difference there is that the interns take very long lunch breaks from 1 till 3 p.m., which would also be unheard of in New Zealand and probably in the UK as well, which I always found quite funny. So they would kind of disappear for a good few hours and tell me to come back later on in the day. And then we'd go and get local lunch from the kind of staff, I guess, like cafeteria equivalent, which was always in SEMA, the maize flour kind of pancakey things, which I'll show a few photos of later. Um, yeah, and then could be home from 3 till 5. You could leave earlier in the day if you wanted to, but I was usually there till around 3 till 5 p.m. And there was also good opportunities to go to teaching with local students, the medical officers who do the 3-year degree and aren't quite qualified as doctors afterwards, but still have quite a good kind of general knowledge. So I went to lots of the teachings with them. Sometimes the tutors would get me to help out and explain examinations. Like I remember teaching some of the students the cranial nerves exam. But yeah, that had kind of range from lots of topics depending on what you were on. I went to liver disease teaching with them when I was on general medicine, and a schistosomiasis teaching, and during obs and gynae I went to lots of different teachings, like C-sections and different presentations. So that was also really helpful for my learning too. And then in the evenings, I'd always go down to the local market and get, fresh local ingredients for dinner, which was really cheap. So that was really good. And it was fun going to the market every day as well. And nice to go for a walk outside too before heading back home for the night. Here's just some photos of my time there. This one on the left is us on our walk to the hospital. The one on the right is the labour ward, and that's one of the birthing suites in the labour ward. So fairly clean, which is good. And that is a photo from theatre. And just a few more photos. This was the team of the Obs and Gynae team in the handover room there. And this is what we had for lunch every day, the ensema, the maize flour pancakes and the rice and the beans and things that you could get with it. So yeah. Yeah, so while I was there, I learned a lot of skills, particularly physical examination skills, mostly due to the language barrier. Because although while ward rounds and the handovers and also the notes were in English, a lot of the local women coming and presenting into hospital didn't speak very good English. But I did actually work with some of the local students to admit people, but I would end up doing the physical kind of examination, which was still really beneficial for me. So, particularly in obs and gynae, where it is a lot more exam based as well. So, I got really good at doing vaginal exams and monitoring progress in labour. Yeah, the midwives there were great, and they would kind of work with me and like check that I was doing everything correctly, and would compare, and they would tell explaining how to check everything properly. So that was really really helpful. I learned how to do pregnant abdomen exams as well, learned how to use the periscope or fetoscope, which I hadn't ever used before in Malawi, and all the students there found it hilarious that I couldn't use it at all. But I got really good at using it by the end, and monitoring, yeah, and listening for heart rate. And I found that's been really useful on my obs and gynae run since coming back, as now I'm really good at finding the heart when using the ultrasound Doppler, so that's been great. Did lots of speculum exams, particularly in the gynae clinics, and all the STI swabs and some cervical smears as well. Improved my suturing skills. I got to suture up some basic tears on the perineal tears on the labour ward, and also got to close a few times in theatre after cesarean sections, which was fun. Um, Often, yeah, got to do the controlled cord traction by myself and active management of the third stage, and even got to do a few deliveries towards the end of my time on the labour ward. I think I did three in the end. Yeah, where I was leading them. But yeah, once again, always with senior supervision, which was really, really nice, and really fun for me as well. And yeah, also learned a lot of professional skills too. Yeah, I kind of mentioned before working around the language barrier, because a lot of the women didn't speak English, and we learned a bit of Chichewa, which was actually really helpful. Medics was really great with that. I found just the basics, even though I couldn't speak very much like in the hospital in terms of medical terminology and taking a history. At least I could say hello, and I learned how to ask a few basic questions and ask for things like consent, which is really important. Um, and it was quite fun working with some of the students to admit people onto the labour ward, because I'd get to sit with them and hang out with them all day and get to know them and get to know more about the culture as well while we were admitting people. And while they were kind of doing the paperwork and things, I could see what they were writing down in terms of the history and things that they had asked them, so then I could ask them to ask follow-up questions for me, and then we would kind of do the physical exam together, and they would lead me to do the physical exam. So it was kind of nice from a teamwork perspective as well. Yeah, and I guess finding I really enjoyed the Obs and Gynae team there generally, and I felt like I had a really good connection with them by the end of it, which is quite special as well. And it was despite all of the vast cultural differences between us. No one there knew where New Zealand even was, and so I'd often pull up a map and show them where New Zealand was and say it had taken me 35, 40 hours to fly there, and it was all just so fascinating and so different to many of the people there. You obviously have to get very good at the kind of learning to adapt and being quite versatile in such a different healthcare system as well. They didn't have many basic supplies, like even just doing urine dipsticks, looking for proteinuria and preeclampsia. There was just no like containers to do that in, and so you just use rubber gloves instead. I think there was only one X-ray machine in the whole time that we were there, and the CT scanner was broken. And then do like things like CRP testing. So yeah, just things I guess that we take for granted that you don't really have to think about. Yeah, you really have to think about it when you're there. And yeah, you really get out what you put in. You can kind of probably make them as most of it or as little as you choose. But I had a really great time kind of putting in yeah, putting in the hours and sometimes and getting to know everyone there. And I feel like I got a lot out of it and learned so much. And I think it's also important to go over there with a kind of non-judgmental and very curious mindset because practices are different from home. But I think the doctors there, particularly the interns who are, PGY1 or FY1 level, know so much for the level that they're at. Obviously, because they are more junior and they are the ones running the wards most of the time, mistakes do get made. And I think you just kind of have to look at that in the wider context of things and consider people are just really doing the best they can with what little resources they have. So I did see a lot of really different and interesting presentations while there as well. One of the things that I found more hard, I guess, was finding out that in Malawi abortion is illegal. And the framework's very highly restrictive, kind of only allowing abortions to save a woman's life. And obtaining an abortion for any other reason, like maternal rape, is punishable by 7 to 14 years in prison. Um, and so in practice and reality, various methods are still used to manage abortions, and doctors manage incomplete abortions very, very often. Um, but this can lead to, I think I was told they often use like local medicines and things to try have an abortion, and often this is partly successful, doesn't work that well. Um, and it's quite a common presentation on the gynae ward. And the majority of clinicians are also religious there. And so, but interesting speaking to them, they all agreed that abortion should become legal. And I think it's probably due to their background as doctors and I guess seeing the complications from that so often as well. Um, and yeah, so we saw a lot of kind of retained products of conception and septic abortions. The main method that they tend to use there is manual dilatation and curettage as opposed to manual vacuum. That's just from what I saw. But they did say that there was the manual vacuum aspiration what was an option. It just didn't seem to get used as much, which also obviously that manual dilatation and curettage carries a higher rate of uterine perforation and bleeding as well. So it sounds like there's kind of a bit of a movement going towards legalizing abortion in Malawi due to the financial burden it poses on the health system from treating kind of these unsafe complications from the unsafe abortion. So hopefully it will change in a few years, but who knows? Yeah, and then I guess once again, lots of the infectious disease kind of pathology, like in pregnancy though, so malaria, HIV, STI, syphilis, which all lead to maternal and neonatal risks, including like stillbirth, miscarriages, low birth weight, maternal death, and neonatal mortality. Unfortunately, a lot of these just kind of go untreated during pregnancy because although while antenatal clinics are available, the majority of people just don't attend them. And so they kind of lead to more late stage presentations or lead to the complications like stillbirths and low fetal birth weight. And that's due to a combination of factors being, women living have really poor access because they're living in really rural areas. There's kind of a general mistrust in a lot of traditional medicine and as well, unfortunately, in Malawi, is what the junior doctors were telling me there. And yeah, and just the low kind of ability to then afford those basic treatments as well for like STIs. I saw a lot of chlamydia in pregnancy, and when looking back through the woman's kind of health passports, that had been noted that it was present for like several months and doctors had prescribed doxycycline or another antibiotic for it. And the woman just hadn't picked it up because they just couldn't afford the antibiotics to do that. Yeah, which is quite sad as well, really. Yeah, and then so yeah, saw severe preeclampsia progressing to eclampsia as well at one stage. So saw someone having seizures from that, which is also very intense and quite scary and something I think you would never see in a developed country as well. And then saw lots of schistosomiasis and bilharzia and the complications from that as well. Lots of people would come in with hematuria and fevers and abdominal pain. And I learned that it can progress into bladder cancer and that bladder cancer rates in Malawi are also quite high. So yeah, that was quite interesting to see too. But generally, I think Malawi was, yeah, I had the best time in Malawi. It was the greatest place I think I could have gone on my elective. And I found Medic to be so supportive during it as well. And they really set us up and gave us the right tools, I think, to do well there. Malawi is known as the warm heart of Africa, and all the people that we met there were so lovely. We stayed with Mr. Chitala, who I'm sitting with here on the left, and he invited us to a graduation ceremony one evening for two local university students graduating, and we got to go there and spend the night and have food with everyone. And there was dancing, which was really fun. Um, got to know lots of the staff in the hospital a lot better. There's some of the medical officer students that I was with and teaching one day, and this was walking to the market one day and meeting some local kids there. More teaching. Lots of time with lots of the really cute kids, which is fun. Everyone always wanted photos as well. I was in theatre. We did a photo shoot in theatre, which would also never happen back here, but people loved that. And yeah, and in Malawi, there's also just a huge range of activities to do outside of the hospital as well, which we definitely made the most of. Um, yeah, this is Lake Malawi here, which is beautiful. Went on a few safaris as well and saw like a full range of animals. Saw cheetah, lots of hippos, elephants, warthog as well. And also went hiking, which I love hiking, being from New Zealand too. So that was great. Went up the Zomba Plateau several weekends and went and did Mount Mulanje as well, which is 3,000 meters high with our amazing guide Sean. So yeah, had a great time. I feel like really made the most of it inside and outside of the hospital. And yeah, that concludes my presentation. If anyone has any questions, feel free to ask them.
Oh, that's amazing, Tamara. Thank you so much. It's so nice to see all of the pictures and
All the photos.
reflection.
Yeah, I have so many photos.
No, that's really lovely. Yeah, no, that do you have a best bit like from your travels? Was there I know you mentioned
Ooh.
Melange, but yeah, if you had to choose, is there a
Yeah.
favorite one?
Honestly, probably Melange was the highlight. I really loved it. It was such a nice way to finish our time, I think, there. And nice to go, like, Sean was the best guide. I love Sean so much. He was so
Oh,
great for that. And it was nice to see Ollie and Liam for that as well and join up with others. And it was just, yeah, like I feel like it exceeded all my expectations. So yeah.
oh, that's awesome. That's good to hear. I hear good things about Melange, and I have done Melange a couple of times, but
Mm.
I just
Yeah, I remember you'd said that.
yeah, I just I don't like going uphill, which is a problem with going up a
Yeah, fair
mountain.
enough.
So
It is quite
yeah,
steep uphill as well.
it's just there's never ending uphillness. But no, but it's lovely. Great views from the top, isn't it? And yeah, your photos look amazing.
Yeah,
Um,
yeah, yeah, it was beautiful.
oh, that's awesome. Thank you so much. I know you've got to rush off, so we're just very grateful that you were able to come and do your presentation. It's great to hear all of your stories and about your time in Zomba as well. Sounds all really positive. So thank you for
Yeah,
sharing all of
yeah,
that.
that's okay. Hopefully it's helpful for people. Yeah.
Oh, I'm sure it will be. No, that's awesome. Thank you. Um, Great. All right. Well, we've got Sean and Isaac online now, which is fantastic. So, Sean and Isaac, if you're ready to go, feel free to share your screen and kick off with your presentation as well.
I will share the screen. Is that good?
Awesome. Yeah, we can see it. That's perfect.
Perfect. Okay. So hello everyone. And thank you for coming to our short talk about our summer in Malawi. My name's Isaac and I'm presenting with Sean. We're UK medical students who spent our summer electives in Malawi. Just to give a quick background for what we got up to in Malawi. I arrived a week before Sean and spent some time at Mwanza Hospital in Blantyre. And when Sean arrived, we travelled to Zomba Central Hospital, as Tamara was saying, where we spent 2 weeks. We then travelled to Mwanza for a couple more weeks, which we'll come back to a bit later on. Sean then left me to spend some time in Ghana, and I travelled south to Nsanje, where I spent 2 weeks at Trinity College. But as Tamara was saying, there's so much to do in Malawi, and we made the most of it, I think. We spent the weekends doing other things. So we went to Majeti Wildlife Reserve, saw lots of animals. Went to Cape Maclear to see the lake, which was a very nice weekend. We also went to Melange, which was amazing, and I think probably our highlight as well. And we went to Tamworth Tea Estate, which was very beautiful. So today we wanted to focus on our 2 weeks we spent in Mwanza, where we did an audit of Mwanza District Hospital, of the facilities and resources that they have there. To give some background on the area, Mwanza is a border district in the southwest region of Malawi. It spans 826 kilometers squared and is estimated to contain approximately 130,000 people. It's famous within Malawi for citrus fruit agriculture, though unfortunately this is an industry in decline. So Mwanza District Hospital has 250 beds, so a lot smaller than Zomba, as Tamara was saying. Um, and that's spread across 6 different wards, including male, female, pediatrics, and 3 maternity wards. There are also 2 operating theatres, an outpatient department, a small emergency department. Um, yeah, and the hospital employs 3 doctors and 3 clinical officers as well. So our audit that we did aimed to look holistically at the hospital, and we broke this down into 3 broad categories: the facilities, the resources, and then the service provision. Within facilities, we looked at infrastructure, radiology, and the pharmacy. Within resources, we looked at staffing levels, equipment, and the laboratory. And then within service provision, we focused on maternal and child health, outreach, and the outpatient department. Having performed the audit and spent 2 weeks in Mwanza talking to different doctors and healthcare staff, we identified 4 areas which we felt were specific challenges to the provision of effective healthcare within Mwanza. These were unique demographic factors related to the population, poor health literacy of the population, it being a low resource setting. Obviously Malawi is, just due to economic factors, it's quite low resource. And then also the unreliable infrastructure within the hospital and also around the region in terms of moving patients around. So I'll briefly touch on the unique demographic factors within Mwanza before handing over to Sean. So as I mentioned before, Mwanza is a border town with Mozambicans frequently crossing for access to better healthcare. And this creates a challenge and increased need for services, a language barrier, and cultural differences. The healthcare system has adapted in some ways. For example, they said they're more likely to admit expectant mothers from Mozambique who may have challenges in traveling to and from the hospital multiple times. However, it's still a challenge with most clinicians not speaking, speaking limited, if any, Portuguese. So communication is a big problem. And as far as we understood, there's no formal agreement between Mozambique and Malawi in terms of patients coming across the border. Secondly, Mwanza is largely rural, as with much of Malawi. The majority of people are living in small villages, scattered around the district, and this creates a huge challenge huge challenges in accessing even basic services, especially related to maternity. To combat this, there are 3 health centres which have a single clinician and are open 24/7, and 10 smaller health posts with more limited resources and opening times located within the community setting, so located throughout Mwanza district. However, connecting all of these to Mwanza are roads which are quite poorly surfaced and maintained, and so access to these remote areas is often challenging, even during dry weather, but during the wet season it becomes especially difficult. To overcome this, they have 5 functional ambulances, though they're for transport only and don't contain any medical equipment. So if a patient's quite unwell, then it can be very difficult to transport them. There are plans to open more health posts and to convert existing health posts into health centres in the future to expand the healthcare provision within the district. So now I'll hand over to Sean.
Thank you very much, Isaac. So taking over on the second healthcare need we identified in Mwanza. the fact that it's a low resource setting, we saw quite a few examples of this coming into play when we were spending time in the hospital. So I thought we'd share just a few examples and then what's also being done about it. So in terms of radiology, the delivery suite does not have an ultrasound, and there are some X-ray machines. So there's three X-ray machines, but unfortunately none of them actually work. One of them is sometimes functional, but it's a little bit on its last leg, so the doctors are very hesitant to use it. And we only saw it used once in the 2 weeks there. In terms of drugs and whatnot, there's quite a lot of key drugs lacking. The doctors mentioned azithromycin as one of them, and they also don't use any opioids for pain relief because there's no naloxone, just in case there's an overdose. The lab reagents, sometimes they have shortages of using these in full blood count reagents. They're not able to do those blood tests. There's some other basic equipment like oxygen saturation monitors and thermometers. And the female ward also mentioned how they don't have as many good quality mattresses as they would like to as well. In terms of the theatres, so while there are two theatres, only one of them has a functional operating table. And they both don't have any overhead operating lights. So when we went to see a surgery, they had set up a sort of like a very bright lamp in the corner to shine onto the table as opposed to an overhead system. And the other theatre doesn't have any soda lime, so they can't do general anaesthetic in it. So because all of that, only one theatre is actually usable at the moment. Maternity also mentioned the shortage of equipment, like forceps and things, so they can't make as many delivery kits as they would like. And the hospital does have three oxygen concentrators, but these are all also broken. And Isaac did mention actually, but with the ambulances, we were told they used to have medical equipment in them, but because of lack of resources and budget cuts and that sort of thing, that's been taken out, and now they're just purely for patient transport. So quite a few examples of where having a lack of resources does play into how healthcare is provided in Mwanza, and it can impact healthcare. In terms of what's being done about it, there's things such as the HemoQ. So this, for example, just gives hemoglobin, and that can give basic blood results when you've run out of reagents, like for the full blood count. They've also got some rapid tests, like the malaria and HIV rapid diagnostic test, which doesn't require like machinery or like high resource equipment. And then finally, adaptive practice. What we mean by this is a lot of the time when they didn't have a first line drug, they would opt for second, third line drugs. And then also, if they can't do certain investigations, they will just treat under the assumption that it is a certain illness and just treat for that. For the future, so one of the themes we noticed was that, as I mentioned, there's quite a lot of equipment there that is there, but it's just not functional. So it got us thinking a bit about kind of sustainable donations because a lot of equipment is donated by other countries and that sort of thing. So if when these countries donate this equipment, if they also teach the people on the ground how to fix it and maintain it, then that could make it a bit more of a sustainable process. Yeah, so that's low resource setting. The third healthcare need we identified was poor health literacy. So a lot of the patients don't or aren't as knowledgeable as we'd like them to be about their health conditions. But the hospital does put on certain things. For example, there is seminars for expectant mothers around childcare and pregnancy that they hold at various stages of pregnancy. And also, they do hold teaching sessions in the outpatients department. around living healthy lifestyle, and they hold teaching sessions about certain diseases as well. We were thinking for the future, maybe the hospital could think about outreach at schools, maybe with a focus on sexual health, because the HIV rate in Malawi is just under 10%. So maybe if there was a bit more like education around that, then maybe that number could go down a little bit. We were also quite surprised to find that quite a significant proportion of the patients aren't literate at all, so they couldn't actually read or write. So maybe this is a little bit out of our scope, but if the government were to invest like more in education and then the percentage of the population that was literate increase, and that would obviously improve health literacy because patients could read leaflets and doctors could write notes, and it would just make the whole process a lot easier for patient and doctor. Something else we noticed was that patient compliance with medications is also not great. So, for example, with a lot of blood pressure medications, patients would stop taking them when they felt like they were better, but they didn't realize that it's actually like a lifelong prescription. You have to keep taking them. So, giving clearer advice and guidance around the management of these chronic conditions would also be helpful. And finally, just some points about infrastructure from our audit. Um, so electricity was can be on and off with the quite frequent blackouts, both because of weather and just because of electricity provision in the country in general. As I mentioned, there is only one working theatre at the moment. They also do have oxygen as in this kind of main line pipe system, but they don't use it that much. They prefer just using cylinders, like oxygen cylinders. And finally, some areas, such as in outpatients, don't have running water. So for that, they use buckets and soap for hand washing instead. But there are a few future plans in place. For example, they're planning on putting solar panels on some of the buildings, so that'll make the electricity provision a bit more reliable. And also, they are planning to expand the theatres a bit and add some more theatres. Because at the moment, if you have an emergency and you're running through an elective list, it disrupts it if there's only one theatre. So having more theatres will help that a lot. So yeah, that concludes our presentation. These are the four healthcare needs we identified. The unique demographic factors, the poor health literacy, low resource setting, and unreliable infrastructure.
Oh, that's
But thank you
amazing.
very much for listening.
Yeah, well done, you two. That was great. That was such a comprehensive audit that you guys did. Thinking of the things that you picked up on, because those were some amazing observations there. What do you think in terms of our like future elective students? What do you think could really make a difference for Mwanza? In terms of if you had to pick one of those priorities, like yeah, is there a project in there that you've thought of for potential future students?
That's a good question. Um,
Sorry, I put you
I
on
think we
the
can
spot.
have a bit more of a think about it. Like specifically, no, it's a good
There could
question.
be
Probably
something in
should
the
have thought
health
about that.
literacy in maybe like asking patients post consultation how much they understood from the doctor or that sort of thing.
Yeah.
Um, there could be
Was
something in there.
was there you mentioned there was kind of the education sort of going on. Was it for the antenatal clinics mostly, like doing the education in the outpatient department? Was that right? I just wondered, because I always think when going into
For maternity, I think we saw maternity.
carry on, Isaac. We've got a delay in the Zoom, but
Oh,
you
sorry, go on.
comment on something. Yeah, you carry on.
Okay. So I think with like maternity, there was we saw that one, but then they said in outpatients they also did them, but we never saw those. That's all I was going to say.
Okay. Yeah, because I always think going into the hospital, sometimes the waiting rooms are so full, and I just think that's actually such a good opportunity to capture that massive group of people and do like if there was a group that did a play or something, kind of for entertainment, but also had that health literacy component in it as well, like that would be like such a good opportunity. But no, that's really interesting, all of your observations. That's fantastic. And Isaac, you went to quite a few hospitals. I mean, Sean, you did as well because you went to Ghana straight after Malawi. So I guess I've got two questions. One for Sean. So if you had to kind of compare your experiences between Malawi and Ghana, what would be your main sort of observations? And then I've got a question for Isaac as well.
Oh, I think the Ghana health system, I think the main difference, something interesting is that the Malawi health system is free, because it's so like supported by foreign aid and that sort of thing. But in Ghana, it was kind of similar in terms of me observing how healthcare is conducted and that sort of thing, but because it is paid, it was a bit of a weirder dynamic to look at, also coming from the UK, which is also free, because it was like, we want to prescribe you this drug, but we can only actually do it if you can pay for it yourself. And then certain like elective, like a hernia repair, for example, is quite expensive. So a lot of people just walking around with hernias because they just don't really want to pay for it to get repaired, which is quite interesting.
Yeah, so every patient in Ghana has to pay, like even at government facilities, there's a charge like to it, as it were.
Yeah, yeah.
Okay.
But you
Oh,
can get insurance, but it only covers certain things.
yeah. Oh, okay. Oh, I didn't realize that. Um, all right, Isaac, my question for you, because you went to four hospitals in Malawi, like what do you think was your um I guess what which was the hospital that you really enjoyed being at? Like because you had such a flavor of all of them. Was there any particular hospital which stood out for you?
I think because Tamara was speaking about Zomba, and Zomba was really good because it was so big, and so there was like a lot to see, and each day I felt like I saw different patients, whereas with Mwanza, it was like quite often you see maybe the same people, which has its benefits as well. But I think with Mwanza, they were much more like it felt much more like they got you involved and you could get hands on kind of as much or as little as you wanted. And they were supportive, but they were also maybe there was just less people there, which made it maybe a better learning experience, I felt. And so I probably enjoyed Mwanza the most. I'm not sure how Sean felt with the difference between Zomba and Mwanza, but I definitely enjoyed Mwanza more.
Oh, awesome. That's great to hear. I'm sure like yeah, the volume of patients at the district hospital and the fact that there's no other kind of elective students there, that's kind of quite a good opportunity for learning and seeing pathology. So no, that's great. Would you agree, Sean? Did you have anything else to add in kind of between Zomba and Mwanza?
Yeah, I really enjoyed them both. I felt like Mwanza, because it's smaller, it's a little bit more free flow, so you can kind of rotate between departments if one of them is nothing's really happening. Or you might like follow a patient to theatre, for example. But I feel like that's a bit harder. It was in Zomba, it was kind of more like you should kind of pick a department. But in Wands, it was more like you could explore the whole hospital, which I quite liked.
Oh, that's awesome. Oh, no, that's cool. Well, you guys were our first ones going to Mwanza, and it's so great that you've given such good feedback about it because we've got two students going to Mwanza so far for 2026. So hopefully we'll get a few others. But we're really grateful to you for doing that audit because it does just help us share information for future students coming as well, which is yeah, which is really awesome. So thank you so much. That was really interesting. You're very welcome to stay on for the rest of the kind of presentations. We've got two more student presentations, but you're also very, like, I'm not offended if you leave. That's also okay. So feel free to have a good Friday evening. And thank you for presenting. We're very grateful. All right, and it looks
Thank you, Tamsin.
Oh no, thank you. All right, and it looks like Scott has arrived, so we'll do Scott's presentation next. So Scott, over to you when you're ready. You should hopefully be able to share your screen. So yeah, whenever you're ready, works for us.
Oh yeah. Yeah. Cool. Sorry, my camera still doesn't work for reasons unknown.
No worries. That's fine. It's probably better for the Wi-Fi connection at the moment, so that's fine. Cool. It's just loading. Oh yeah, we can see it now. Perfect.
Cool. Yeah, fine. So I'm Scott. I'm a final year student at Glasgow Uni. I did just a 4 week elective on the Likoma Island over the summer, just past. I was going to talk just quickly about getting there and accommodation and kind of what it's like once you're on the island. And a little bit why I think it's important to try and do a bit of travel on the mainland, either before or after the elective in Likoma, and then there's a slide on funding at the end as well. So getting there, obviously, Tamsin, I know you tell the students kind of all about that, but essentially, yeah, it takes 3 days, so you do need to leave a little bit of time. I think generally, especially if it's the first or the only kind of site for your elective, then you kind of fly into the long way and travel north from there. The reason I've kind of put this slide in mostly is because, or is about the Alala, which is the ferry that takes you over. I think it was built in Glasgow 75, 80 years ago, so we've got us to blame for it. But the main thing is, I read quite a lot about it online and was a little bit worried about it going over to Malawi. So I kind of put this slide in just to say it's not actually as bad as Google might make you think. And it's not particularly comfortable, but everyone just kind of gets on with it. And it's actually a really cool experience to have as part of your elective. When you arrive in Likoma, kind of all memories of the Alala are gone. So stayed at Mango Drift, which is a backpackers on the island. There's lots of swimming and kayaking and snorkeling. This is the hut that I stayed on the beach. There are always people around, so I went on my elective on my own. But well, that's yeah, kayaking. I went out to see the fish eagles most days was really cool. But yeah, there's always people about. I travelled on my own, but I still got lots of texts like this frequently and from very early on in my elective. So it was a really nice place to stay for that. And the sunsets were pretty brilliant as well, and were different every night. And the pictures were never quite as good as the real thing. Mango Drift right next to a fishing village as well, so you kind of see all the locals as you go in and out of the backpackers, and you also kind of wash your clothes in the lake and stuff alongside them as well. So although you're clearly living a very different life, you kind of feel somewhat integrated in the whole thing. There's also always kids about as well, and if you make the mistake of buying them cookies on the second week, then you spend a lot of time with them in the end. So St. Peter's Hospital is on the other side of the island, and you kind of use motorbike taxis or cycle there. The pictures there just show the maternity unit and just outside where they do handover, which was quite interesting, doing handovers in the morning outdoors. I had this as pros and cons, these lists originally, but to be honest, I didn't really think there were many cons about the whole thing. It was all worked really well for what I was looking for in an elective. So the pros that you got to practice lots of histories and exams with a translator. Essentially all of the Malawian residents there speak speak only really Chichewa, because it's quite rural, and you get a lot of patients coming over from Mozambique as well who only really speak Chichewa or Portuguese. I found it really, really useful to practice exams and histories with a translator. It's something that we do more and more back home now as well. So yeah, it was good, and it was actually really good fun as well, trying to do like a cerebellar exam with someone who doesn't speak any of your language essentially. The presentations were really interesting. So saw some sickle cell, lots of malaria, and there was a family were attacked by a buffalo as well at one point in Mozambique, so they came over. The presentations were always often quite late. I think I don't know, I heard you in the last talk talking about how patients have to, so they've got states kind of sponsored healthcare only, but St Peter's is a CHAMP hospital, so they do need to pay a small fee, and I think that did put off some patients from coming in. So you saw later stages of disease that you maybe don't see at home. The staff were really nice, and there was loads of obs and gyn presentations. So you got really good practice of histories and speculum and bimanual exams and things, which I actually got far more experience of that in Likoma than I did kind of back home on my obs and gynae block. Challenges are there are no doctors at the hospital. It's just clinical officers whose knowledge is quite rudimentary. So you're often asked to make decisions and give advice, give suggestions. This was a little bit of a shock at first, but actually you find that it's quite useful and that you really do have to think. What was I going to say? Yeah, you also learn kind of when to step back from situations when you maybe do feel you're a bit out of your depth, but you're never asked to do any of the kind of really things you hear about people doing electives like this, having to do lumbar punctures on really sick kids. You never have to do anything like that. I'm never asked to do anything kind of really scary. I put English not widely spoken among patients as a challenge, but as I said, it was actually a pro in many ways as well, because you got good practice. Supervision levels are low, and you do need to be quite motivated to kind of get educational opportunities, I would say. So did a project, so I was there, so we made up 50 mum and baby kits. So it's a picture of them on the right there. Just kind of had sanitary pads, reusable sanitary pads, maternity pads, blankets, cardigans, underwear, baby hats and teddies and things. It was a really good fun project. The organising of the whole thing was in the first couple of weeks, and that was done in that kind of tiny little cupboard that there's a picture of there. So it was quite challenging, but giving out the kits was really lovely. I saw lots of really cute babies. In future, I think trying to get some kind of audit of how the kits went, and if they've encouraged mums to come into hospital to have their babies, because it's still quite common in Malawi for them to give birth at home. And then talking to Tamsin as well, we kind of thought that an advice line for clinical officers to use, where they could speak to a doctor and get advice for patients, would also be really useful, given that there were some questionable decisions made while I was there. Extra training as well potentially could be offered, I think, by elective students that go over just on simple things and like refresher courses for clinical officers, because I think once they finish their kind of degree, there's not much kind of like postgraduate training for them, from what I understand. I was a bit worried there wouldn't be much to do on an island in the middle of the lake. I'd got like 7 books to read, but ended up only reading one because it turns out that there was always stuff going on weekends and afternoons. It was one of the most kind of must have been one of the most scenic football pitches in the world, and there was always all kinds of traditional dances and competitions and things. It's also a tailor's just round the corner from Mango Drift, so I spent a lot of time there getting all sorts of Chitenji fabrics tailored to things like dressing gowns and pillowcases. Great. There's obviously the cathedral and everything as well, so that was really nice for Sunday church services. We went just once to see that, and it was really lovely. I was asked by the uni just to make up a poster, essentially just to prove that we'd gone on an elective, but they asked me, what did you learn from it? And I think my kind of ultimate take home was that you saw really pretty negative patient outcomes as a result of preventable disease happening because of kind of not poor expertise. The clinical officers always worked within their means, but the fact that there was no doctor there would say that there was a fairly low level of medical expertise and the low levels of resources as well. Seeing that made you realise just how much of a difference you can make for patients if you're a good doctor using adequate resources and good resources. You don't see such poor outcomes back home because they don't happen because we're kind of lucky enough to have a really good health service. So seeing what can happen without good doctors really is quite motivating, I think. I also got a kind of better appreciation and better confidence in my own abilities, I think. I'm always quite complacent back home seeing patients because I always know that whatever I see or do with a patient, a doctor's always going to be looking over my shoulder and essentially corroborating everything that anything that I've done and filling in the blanks that I've left. In Likoma, you couldn't really do that. If you saw a patient, then you were kind of making the plan for them as well if you felt comfortable, and your history and exam wasn't going to be kind of corroborated by the clinical officers. So I found myself being really, really thorough and not kind of leaving a patient's bedside until I was really confident that I'd got all the information. And I think that was I think reassuring when I look back on it. So when you go to Likoma, I think you get very much a kind of island experience rather than an experience or an appreciation of the whole of Malawi. You see so much more, I think, on the mainland of what everyday life is like for Malawi, and so I would definitely recommend trying to spend a bit of time on the mainland rather than just going to Likoma. The scenery is amazing, and getting to see more of the people going around their everyday lives is really interesting as well. So hiking in Malanje, there was these ladies that would get up very early in the morning, hike hundreds of feet and get firewood to bring all the weight back down, and sell, as a way of making a way of making an income. And they're doing it all without shoes, without water, without food, and they just looked exhausted. And like, I've never seen anyone go to those ends to make a living before. So yeah, it really made you think. And it's not you didn't see that kind of poverty to that extent in Likoma, I don't think. The roads, they're just so different from home. They don't have roads in Likoma, so it was something that I found perplexing all the time, and it was so interesting to experience. The scenery is brilliant, as I said, and again, you get the chance to go on safaris and see lots of the wildlife, which you don't get so much of a chance to do in Likoma. Other things I put on that list, there's just things like the markets and the importance of religion in the lives of Malawians. It's all just so different from home. I just got the chance to meet a few medic students just before I went to Likoma, and once I was back on the mainland, it was a really nice thing to be able to do and see where the funds were going, and they were always so grateful for everything. The village visit and getting to see the kind of aftermaths of Cyclone Freddy 2 were kind of quite important parts, I think, and when I look back on my elective, are quite prominent. Yet they happened something like 10 days after my medical elective itself finished. So I think, yeah, it's definitely important to make an effort to get to the mainland and see things like that. And that was the Chitendi at the markets. It's a petrol station, and yeah, that was just the route that I took coming over from Likoma back to Katabe, and then traveling south from there to Blantyre and spending some time in Malanje before flying home from there. So just to add to the kind of village visit, an idea that electives are for more than just medicine, I've included this slide on environmental injustice. The concept that climate change and global warming are primarily driven by the industries of wealthy countries, such as in the global north, yet the effects of climate change are primarily felt in poorer countries of the global south because of their kind of vulnerable geographic location, inability to protect against kind of climate events and poor ability to recover afterwards. I think the events of Cyclone Freddy are a primary example of that. And this book, where this guy uses lots of very long words, is quite good on the issue. And I think this sentence about sums it up when he says the so-called Global South experience environmental threat not as a planetary abstraction, but as a set of inhabited risks, some imminent, others obscurely long term. I think spending some time on the mainland away from hospital makes you realise that inequality affects not just healthcare in countries like Malawi, but almost kind of every other facet of life as well. A note on funding, Tamsin had suggested I include it. So of course, fundraise for your project. That's kind of how I did mine. But apply for bursaries and scholarships too. This isn't something I'd really ever done before. But my uni were really good at sending out different funding opportunities, and I would say just apply for everything that you see. I applied for these 4 and got the first 3, and they said the reason I didn't get the 4th one was because I already had three bursaries. So I definitely recommend just applying for whatever's out there. I was going to put a link to kind of websites and things that put lists of elective bursaries and different opportunities, but they're so easy to find. You just need to Google it. These ones specifically, so the Royal College in Glasgow, they do 8 £1,000 bursaries a year. 3 of them are for Glasgow medical students. The remaining 5 are kind of fair game for any UK medical student. The Worshipful Society of the Apothecaries, and the coolest society ever. But yeah, they do £400 bursaries every year. That was the kind of easiest of the bursaries to apply for. I think it was only a few hundred words. And yeah, it's really helpful. Then the third one, I think that's for Glasgow Uni only. I think it's an alumni student that has maybe retired or passed away and has left a fund for electives. So yeah, I think it's just for Glasgow students, but I don't think it's uncommon. So other unis maybe do something similar. And then the last one I think is a kind of UK-wide thing. I think it's maybe distributed through universities individually. I'm not too sure, but yeah, worth looking at that. And then just Googling generally for different funding opportunities. It can contribute to your project, or if you fundraise money for that, then this is a really good way to put towards traveling there and elective fees and things. Kind of finally, why Malawi? I think you get a proper experience of healthcare in a truly low resource setting. It also changes the way you think about medicine and life generally. And you also get the chance to organise it through Medic to Medic, which was yeah, really helpful and valuable, really. And yeah, if I was to organise it again, I'd go the same route. Thanks for listening.
Oh, that's wonderful, Scott. Thank you so much. You've got some really beautiful pictures there. I think everyone will be wanting to go to Likoma now with those beautiful sunsets and life on the beach. Did you find like living on the beach challenging? Like, was it because like it can be quite basic mango drift, can't it? Like you haven't got like an ensuite or anything like that. It's yeah, was it did you have any challenges kind of there at all?
Yeah, I would agree. Yeah, because yeah, they're certainly basic compared to home, but I guess compared to what else I saw in Milan, it was pretty plus.
Yeah.
I really liked it, but yeah, I think you need to be prepared to shared facilities, and the room's fairly basic and very open to the outside, which was really nice. And you were kind of woken up by the sun and the birds and things, which yeah, it was nice, but yeah, basically.
That's awesome. That's really cool. Lovely. Well, yeah, I don't think I have any other questions. Maybe Sean and Isaac do. They're still with us, which is nice. But yeah, thank you very much for coming along and presenting. I think it was really interesting as well to learn a bit more about kind of the funding options, because I know sometimes people are people want to go overseas, but maybe they haven't got kind of the same means or budget. So it's nice to know kind of that like it for you that seemed like a really good opportunity for funding. So thank you for sharing all of those resources as well, because it's nice to know there's other sort of options around. Lovely. So I think we've got one more presentation. So it's for James. He's unfortunately not available to present live, but he's done a pre-record, which I'm hoping I'm going to be able to share without any problems. So let's give it a go.
Good morning, everyone. My name's James. I'm a final year medical student from New Zealand. And earlier this year, I spent 8 weeks in the emergency department of Zomba Central Hospital in Malawi. So what I want to share with you today is not what I just saw, but what it meant, how medicine under scarcity reshaped the way I think about health, privilege, and the future as my own role, becoming a doctor. Before I left, I thought this elective would mostly be about tropical diseases, but what I learned went far beyond malaria and TB. It was about humanity, its resilience, its fragility, and sometimes its neglect. So why did I choose Malawi? Well, I wanted to test myself, like most people that choose to go to Malawi, to test myself outside the safety of New Zealand hospitals, where back home here in New Zealand, supervision is constant, tests are abundant, and machines are always humming in the background. Zomba Central serves a catchment of about 2.3 million people, and it has fewer than 10 senior doctors in ED. The ED has 3 resuscitation beds, 4 triage beds, and just 2 working monitors for heart rate, oxygen saturation, and blood pressure. Every patient's history lived in a small little battered booklet called a health passport. If it was lost, so was their record. And then there was the city Zomba itself, a city cradled at the base of the Zomba plateau with a beautiful mountain right above it. You can just imagine the minibuses crammed through the red dusted streets, students from the university giving the place a restless energy constantly. And just beyond the city, the rural villages begin. And that's where many of our patients came from. Families that would be walking barefoot for hours, carrying food and bedding, and their loved ones on their back. So yeah, every morning you're struck by the truth. In Malawi, where you live often decides whether you live. In the pictures you can see where Zombas are situated. The service map of Zomba Hospital itself, the hospital next to it, and then that's the Zomba at night, which is actually quite beautiful. So in regards to the population health landscape, these are the diseases I saw every day, and you can only read about textbooks and barely touch them in New Zealand. So HIV affects about 8% of Malawian adults, which is close to 1 million people. Malaria remains relentless, with over 4 million cases each year, making up nearly 40% of all outpatient visits. And there's TB lingering in the background with about 150 cases per 100,000, and maternal mortality stands at 381 deaths per 100,000 live births, which is almost 40 times higher than here at home. In Zomba's ED, these weren't what was known as zebras back here. They were daily bread: cerebral malaria in children, disseminated TB in adults, complications of late-stage HIV that we almost never saw in New Zealand. And the lesson was sobering. In Malawi, what is rare to us is routine to them. So daily reality was something. One afternoon, for example, a mother came in carrying his son on her back. He was semi-conscious, having seizures from cerebral malaria. They had walked barefoot for hours just to reach us, but by the time he arrived, he was critical. We gave artesunate glucose fluids. That's pretty much all you can do with the limited resources in Zomba. But the real diseases had taken its toll, and it was the delay shaped by geography and poverty. Another case, which you might be able to see on the right image, is a 15-year-old boy. He was out fishing in the lake in which a crocodile attacked him, snapping away at his thigh. Much of his thigh was gone. And when he presented to ED, there was no analgesia given. He was not brought in by stretcher. He was carried in by two men. And as the surgical registrar came in, just slapped a soaked cotton bud of betadine on him, pretty much onto straight raw muscle, no hygiene at all, before being carried away by bystanders to the surgical ward. So yeah, it was like moments like these that showed me the suffering in Malawi is not only just about disease or the injury, but about a bit of absence of dignity. And so I kind of vowed to myself, no matter where I work, resources limited or not, there should never be an excuse to lack of compassion. So that was great to have that come again. But yes, systemic and global pressure. Prevention exists in Malawi, but like the nets strung over village huts, it has holes. Only just half of households own a treated bed net for mosquitoes. 1 in 5 Malawians living with HIV remains undiagnosed. Childhood vaccinations reached over 85% coverage, which was thanks to Gavi. But in 2025, USAID was suspended to Gavi and supply chains have subsequently faltered. UNICEF has warned of measles and polio campaigns being delayed because of this delay in funding, and a 10% drop in coverage could mean tens of thousands of extra child deaths in the next decade. Another problem that's been faced in Malawi is the workforce. The World Health Organization say you need about 2.3 doctors, nurses, or midwives per 1,000 people to deliver basic care. New Zealand has about 4. Malawi has 0.3. So some days at Zomba Central, entire wards would be run by student nurses and clinical officers without a single doctor in sight. So prevention as the foundation of health is at risk. So with more than 70% of Malawi's development budget coming from foreign aid, healthcare accounts for about 9% of their GDP, making the system exquisitely vulnerable. When the Trump administration earlier this year suspended $2.6 billion in funding to Gavi, vaccines vanished from supply chains across Africa. And what haunted me was that the survival of Malawi depends not just on doctors and nurses, but on politics and policies thousands of kilometers away. It's medicine dictated by geopolitics. And yet, as I reflected, I saw parallels back at home, obviously not so extreme, but in New Zealand, Māori, Pacifica, and rural communities still face barriers, distance, cultural misalignment, under-resourced service. But the difference is not the problems, but the infrastructure and political will to meet them. But it comes back again to what humbled me most about was Malawi's resilience. Each morning, families would continue to gather outside the hospital, cooking their nsima over the open fires, singing hymns. They had almost nothing, yet they carried their dignity and community with them. Meanwhile, here in the West, we argue over efficiency targets, political correctness, and administrative tweaks. We scroll past global suffering, distracted by comfort, and history will judge this era harshly. We had the resources, the science, the global platforms to act, and too often we choose distraction instead. But what did I get out of it? Clinically, I developed confidence in my systematic emergency care. I was put under the pump, constantly applying my ABCD, and especially doing all this without the access to labs, imaging. You just had to rely on your judgment and my little clinical Oxford handbook. Professionally, I also learned humility, And leadership often meant cleaning the floors alongside colleagues and not just making decisions, which I found beautiful. Culturally, I saw the integration of community into medicine, and there was not just treatment, it was context, culture, and compassion. My time in Malawi stripped away complacency. It made me realize how privileged our systems are and how easily we confuse comfort with progress. Malawi showed me that resilience, ingenuity, and compassion are as vital as any drug or medicine. And it reminded me of my responsibility to carry these lessons back into rural medicine and practice in Aotearoa, which I'm quite passionate about. So, Zikomo Kwambiri, thank you very much. I hope you learned something. And yes, we had an amazing time at the lake. I definitely got schistosomiasis and was urinating blood, but would totally recommend. It's a beautiful place. Definitely have to go to the lake. Thank you very much.
All right, I'll say thanks to James in his absence. I hope people are not daunted by schistosomiasis. It is a risk, obviously, going to the lake. But we do give advice on how to kind of manage your risk as well. So it's a recognized risk, but can be well managed. But that concludes our student presentations. I'm going to go back to my final few slides from our talk for the electives. It might just take me a while just to find the right presentation. Just 1 second. Should be. Sorry, another second. Okay, we should be up and running now. Okay, so this is just the second half of the presentation that we do. So this was just concluding a little bit on some of the student projects that have been done. You've already heard of some of them. But we had 7 students overall that did additional fundraising for their projects or their visiting location. And that gave an extra 2,000 New Zealand dollars and £2,000 because they were done by a mix of our Kiwi students and our British students into the local economy. So all of the project money is transferred to Malawi with no deductions, and all of that money is spent locally. So we do that because we want to make sure that kind of we're improving infrastructure and like helping those local economies as well. So some of the projects in terms of what the fundraising went for included a house for health workers in Nandala village. That's not quite finished yet, but it's almost finished. So after that, we're hoping that we can staff the clinic that's in that village and serves 15 villages. And we'll be able to work with the Ministry of Health. So having that facility will be really useful because it means that we can kind of attract health workers to stay and to staff that area, which is obviously quite a vulnerable area, and it's important that we try to improve healthcare there. We did do, one of our students did an audit of one-stop services in Mzuzu. So that wasn't one that required extra fundraising. So that was just an example of sort of the audits. You've already heard about Sean and Isaac's audit of Mwanza, but it was an example of another audit that we did. So the student was looking at the presentations of cases that came to the sexual assault service. So that's the one-stop service over a 1-year period from 2024. We had some other students, this was mainly on Likoma Island. We were able to provide 150 menstrual hygiene kits to school students on Likoma Island. So that kind of completed the project from last year where 300 girls had received kits. We just had another 150 outstanding. So we sort of completed that project at the schools. And then with that as well, we were able to distribute 550 mosquito nets to the boarding school on Likoma Island. So previously there'd be a lot of school absences due to suspected malaria or having to go to the hospital for investigation of a fever. So we did a sort of audit initially of the kind of the rates of fever and then the confirmed diagnosis of malaria. And we're hoping that now we've done the intervention, our students who are coming up to Likoma during 2026 can re-audit it, and we can kind of compare and look at what the impact has been and if it's actually helped kind of reduce malaria rates in school children. And then you've also heard about Scott's project as well, which was doing the mother and baby packs for women who were delivering at St. Peter's. So we were able to put 50 packs together, which was really awesome. So for some future projects, so if any students are listening and are interested in getting involved in other projects, so we would really like to kind of support and strengthen the one-stop service in Mzuzu. So we've got a few ideas in regards to that in terms of providing an office phone for the service, providing a motorbike so that the staff can follow up cases. Often there's a lot of loss to follow up because we're relying on patients to travel back to the clinic for sort of ongoing care, and a lot of women and patients lack the resources to kind of come back to the service. They don't have the transport money. So if a motorbike can be funded for the staff to then do outreach, then that's one way of sort of hoping to support their work. And the staff have also mentioned about trying to get a husbands club up and running, which sort of tries to, the idea being trying to sort of consider and engage sort of discussion around gender-based violence and other issues, which hopefully will have a knock-on effect of sort of reducing reducing gender-based violence. We would love to continue the mother and baby packs for newborns at St. Peter's. And then we also really like to do a community health survey during 2026 with the aim of doing that in the Nandala village community, just so that we can get some kind of robust data for the health needs of that community, and then make sure that when the clinic in the village is up and running, that it can be responsive to the needs of the community. And Scott also mentioned about the advice line for St. Peter's Hospital on Likoma Island. What we would also really love to do is kind of put together an advice line service where the staff at St. Peter's, but also hopefully maybe expanding it when the time comes, but starting it off at St. Peter's, just getting an advice line in place where the staff can call and talk to doctors or kind of specialized clinicians, whether it's a pediatrician, obstetrician, for cases that they may be struggling with, which will hopefully, like the idea being, sort of improve staff confidence and improve knowledge, but also improve patient care and also timely transfer to the mainland for treatment for patients who are at St. Peter's. So those are our ideas for the future. So I think we've talked a little bit already about sort of elective opportunities, and that some of them have been kind of discussed already, but we like doing the Chichewa language lessons before students arrive and the tropical medicine tutorials. What we're hoping for 2026 is that if we've got a group of students coming out together, or like arriving all at the same time as actually doing a orientation week. So instead of doing the tropical medicine tutorials at sort of via Zoom before coming, we were hoping to kind of plan 3 or 4 days where we would have like quite intensive like lectures in the morning, and then structured bedside teaching at one of the hospitals for that afternoon. But that will only kind of work if there's a group that we can organize it for, as opposed to kind of one-on-one. It will just makes it a little bit more difficult. So we'd love a few more groups of students from the same university to kind of come out at the same time. And not that that means that you all have to stay at the same hospital for your elective. You can still kind of go to different places. But having that opportunity to do the orientation week, I think would be hopefully hugely impactful, and then also kind of reduce the number of meetings that you, and they're not compulsory, but reduces the amount of kind of preparation you do before you arrive, and kind of gets it into the start of your elective to then kind of build upon those learning opportunities at a later time. So in terms of other opportunities, we've mentioned about school talks, the village visit. We do need help with some kind of monitoring and evaluation work with medic to medic students. So we do need to do student interviews. So we did ask Scott to do a few when he was in Mzuzu before he got the ferry to St. Peter's. But we'd love to kind of get that more structured so that we've got more, we'll definitely have more of those opportunities as well, because we've now got more students on scholarship that we need to follow up and just do our annual kind of chats with them. So there'll definitely be kind of opportunities to meet medic to medic students. We also, graduations in Malawi happen throughout the year. So we're not always available to attend in person, or like we're tied up in another region. So we would love to kind of for elective students to represent us at graduations. And this year we did have one student who went along to a student graduation to represent us. So there's definitely opportunities to attend graduations as well. And then with the projects, we're really trying to build upon those projects and the audits, and we always need more hands on deck. So we'd love to kind of get more elective students involved in that. I just thought I'd highlight a few quotes from the feedback we've got from the locations. So a few of the places have said, like, we had a quality time with the student and we expect more students to come. And then another place said it was eye-opening and interactive. It should be highly promoted. So some good feedback so far. We always ask each of the locations to fill out a feedback form after you come. And we do the same with the mentors as well. So every elective student is allocated a mentor. As our locations have expanded now, the mentor isn't always on site with you, particularly if you're kind of splitting your elective between different places, but they're always on hand on WhatsApp as well. So like if we're not immediately available, then you kind of your mentor is your first port of call. And so we got some feedback from our mentors as well, just to kind of keep an eye on if they need extra training or if there's issues or problems that we're not aware of. So yeah, just highlighting a few quotes from the mentors here. So one of them said, "I had an amazing experience. I learned a lot, and it really made me think of myself as someone my country can rely upon. Being able to interact with an international student and making sure their needs are addressed in time and that they are made to feel safe and protected. It's not a simple task. This boosted my initial understanding of myself. And for once, I felt so much important in one's life." Another quote as well, "It was interesting as it was a shift from leading about it and going on to actually conducting the role." So that's good opportunities for those collaborations as well. So just briefly about finances, because I think they're always sort of interesting. I was going to try and sort of do a bit more analysis and just kind of say, well, this is how much we spent on accommodation, etc. But it got a bit complicated with all the numbers. But hopefully I'll be able to do a deeper dive if anyone is interested. I can release those. But essentially, the total kind of income generated from the elective students in terms of their expenses and kind of the fundraising projects, like everything all together, was 66 million Malawi kwacha, which is what we brought into the country. And then in terms of once all the expenses for the students have been taken off, like medical council fee, hospital host fee, accommodation, in-country transport, like all of those things. We had 22 million Malawi kwacha left over, which went towards student scholarships. So with that money, kind of throughout the year, we've been adding new students to the medic to medic program. So we're able to provide 5 students doing the Diploma of Clinical Medicine at College of Health Sciences in the Lilongwe with a scholarship. And then 4 students at Malamulu College of Health Sciences. So this is actually a new partnership. We haven't previously sponsored any students at Malamulu before, but it's quite exciting that kind of the elective program has given us kind of the funds to be able to expand. So we're supporting a degree level public health student and then 3 nurse midwife technicians. And we've also recently just taken on 3 new palliative care students at Kamuzu University of Health Sciences. So we've got a total of 12 new students on scholarship, which is great. And we have done preliminary interviews for a student at Trinity College as well. So we'll hopefully be adding one more with the kind of remaining money that we've got left over from the program this year. So just for future students, if any of you are looking, and even if you're not doing a medic to medic elective, but you're interested in doing the tropical medicine tutorials, which we'll do over Zoom, there are a set of 12 sessions. We basically charge, it's about 10 New Zealand dollars or £5 a session. We don't charge for like 3 of them, so it's a sort of for the set. If you're going to come to all of them, it's £45 for the set or $90 if you're in New Zealand. And the feedback we've had from previous students have said it's been a good overview and a helpful framework for future learning, and it was helpful to focus on the kind of clinically relevant points. So if you're interested in an elective in Malawi, we'd love to have more of you. So we just ask that you drop us an email, or you can WhatsApp me. My number is out on our socials pages, I believe, in relation to the elective. So feel free just to drop us a message. And just put in the subject header elective application, because it just lets us kind of prioritize those emails. And then we just basically organize a Zoom with you to find out a bit more about what you're interested in and what your aims for your elective are, and then kind of take things from there. So thank you so much for sticking with us, and thank you to Isaac and Sean for sticking with us as well. And yes, please do drop us a line if you've got any questions anytime. And yeah, thank you for checking this out.